Hello, everyone, and welcome. This is Ben Knoll. I'm the Director of Patient-Centered Important Topics. As a reminder, we have been conducting these monthly webinars for more than a year now. And during the call, I'll post in the chat box a link to the Creaky Joints website where you can find all of the other webinars that we've done. So you can see what other topics we've covered, and if you're interested, you can view the other webinars or listen in, or just look at the summary comments of key points that we pull out of each one and post on that webpage. So we're delighted to have people join us for this one. We do this in partnership, not just as part of our research activities with Arthritis Power at Creaky Joints Global Healthy Living Foundation, but also with the As Is CRG. You can see the logo down in the bottom of the screen there, and that stands for the Collaborative Research Group, or CRG, that is concerned itself with autoimmune conditions. So it's for autoimmune syndromes and oh gosh, I'm so triple. I might need help. I can't. This was a terrible case if I forgot our own acronym, but for autoimmune and systemic inflammatory syndromes, the Collaborative Research Group that's part of PCORNet, the National Patient-Centered Clinical Research Network. So we invite everyone from the other patient registries that are concerned with these same types of conditions to join for these webinars and discussions. And we try to present research results as we get them, and also to also highlight some topics that, although we may not be currently conducting research in them, we know it's of interest to the patient community and are areas that we want to learn more about and study. So that's what these are about. So today we're very honored to be joined by Dr. Justin Owensby, this fellow you see on the screen before you. He's a doctor of pharmacy and also has his PhD. He's a research pharmacist and also current postdoctoral fellow at the University of Alabama at Birmingham, and he has expertise in behavioral intervention, health outcomes, and evidence implementation. He's at UAB in the Department of Clinical Immunology and Rheumatology, and he works very closely with Dr. Jeff Curtis, who's one of our partners in Arthritis Power. So Justin's research utilizes mobile health, or mHealth for short, things like mobile apps like Arthritis Power, that a lot of you are probably familiar with, and other digital technologies. And it involves applying concepts from behavioral economics to preventive health behaviors, such as immunizations, which we'll talk about tonight, medication adherence, patient education, patient behavior change. His current research focuses on patients with rheumatoid arthritis and other types of inflammatory and musculoskeletal conditions. So with that, we're very pleased to have Justin join us, and I will turn it over to him. And as a reminder, you're all muted, but we would be delighted to have you submit questions to us in the question window that you see in your dashboard. Thanks.
Thanks so much, Ben and Shilpa. Thank you for inviting me, and thank you for having me, everyone. And I hope that at the end of the day, we have a nice discussion that goes on, and any questions that need to be addressed, hopefully I can address them, but if not, my email address is there at the bottom, and you can just email me, and we will get those questions together. So the title of this talk, Vaccination Concerns Among Patients with Autoimmune Diseases. What I intend to cover today is kind of broadly just vaccines, like what are the basics, and then why vaccines are important for you, and which vaccines do you need and which are recommended for vaccinations of patients with autoimmune and or inflammatory disease states. And then of course, have some discussion and questions, and then if you'd like, resources and references. But to begin, each month, as Ben had said, that we run a community poll question with the Arthritis Power members. This month we asked, do vaccinations scare you? And results show that of 773 people that answered, just 27% of respondents said yes, vaccines scare them. A vast majority of respondents, however, 73%, said that vaccines do not scare them. So it is my hope that by the end of the talk today, some of those fears will be subsided, and if not addressed, then at the end, during the Q&A session, or as I said before, we could do this through email. So briefly, vaccines work by mimicking disease agents and stimulating the immune system to build up defenses against them. Vaccines contain the same bacteria that causes infectious diseases, but they have been either killed or weakened to the point that they don't make you sick. So some vaccines contain only a part of the infectious disease, not the entire thing. And because living with an autoimmune disease or an inflammatory arthritic disease, such as RA or MS or some other form, this makes you vulnerable to serious infection, and it's especially important to get vaccinated against infectious diseases. Vaccines, in particular, they strengthen your immune response and protect your health and the health of those around you. So how do they work? The next few slides, what I intend to do is just kind of briefly show you kind of illustratively how the different parts of the immune system respond to vaccination, and then how that response protects the body from a specific infection in the future. The immune system protects the body from pathogens, and pathogens are agents that can cause infectious disease. So a vaccine is like a pathogen imposter, or essentially wearing a pathogen costume. It looks like a certain bacteria or virus to the immune system, but doesn't make the body sick. And pathogens are covered with molecules called antigens that can trigger a specific immune response. So the vaccine is initiated or put into the system, and then it has these antigen-presenting cells. And so there's going to be a lot of details that I won't go over on these slides. It's just for illustrative purposes. But really, the vaccine is entered into the system, and the system is kind of like alerted to an imposter. And then it kind of learns it, and it produces these antigens, and the antigens are what alerts other cells. So the vaccine exposes the body to antigens that are similar to the antigens found on a pathogen. And by exposing as a specific pathogen, the vaccine primes the immune system to respond quickly and strongly if the body encounters the pathogen in the future. For instance, if when we're talking about, let's say, the flu vaccine, and when you initially get the flu vaccine, you're not going to get the flu, so you're going to have a primary response to it, and it's going to kind of learn a weakened version of it, so that when you do encounter it in the future, that your body will be a lot more attuned to what it's seeing. It's kind of preparing it for the test, and then you'll be much better prepared. So what it essentially does is it kind of programs the immune system to remember a particular infectious disease agent, and it allows it to practice on a weakened or a killed version of the pathogen. And so that whole thing is called a primary response to a pathogen, or just something that's been introduced into your system. So as I said before, if the pathogen invades the body again and it comes in full strength, the immune system is ready to respond with a swift and specific defense. And that's called a secondary response to the pathogen. So these responses happen faster and stronger than primary responses, resulting in the creation of more antibodies to fight the pathogen and more member cells to fight it in the future. So with the flu analogy, you get it introduced to yourself up front, and then when you do see it in the wild, that your body is ready to fight. So the next slide will go over kind of how vaccines. There are three types of vaccines that are kind of available broadly. So you've probably heard of live vaccines or live attenuated vaccines, and these are basically the weakened version of the vaccine. And they're designed to produce an infection without symptoms. So these vaccines, they offer long-term immunity. Live vaccines are somewhat more likely to cause mild side effects versus the other vaccine types. However, in people with weakened immune systems, they may not be able to control an infection. And so in general and broadly, live vaccines are not typically recommended for individuals with weakened immune system. The next type is inactivated vaccines, and those are typically the types of vaccines that you would be receiving. They're sometimes referred to as killed vaccines, and they generally have fewer side effects than a live attenuated vaccine, but however, they tend to draw a less strong immune response than live vaccines. So several doses or maybe booster shots you've heard before, they may be required. Tetanus is one example where maybe every 10 years you're required to get a tetanus booster, and that's because the initial shot isn't as strong of a pathogen as perhaps a live vaccine. And the next one is called a subunit, or it's a conjugate vaccine. I think what you may hear out in lingo from maybe in your pharmacy or at your doctor's office is a conjugate vaccine. And for some infections, a specific protein or just a specific piece of that pathogen is created, and then it induces a protective immune response that is then isolated for us in a vaccine. And the influenza virus and the pertussis vaccines are examples of this. So why are vaccines important for you? A vaccine stimulates your immune system to produce antibodies, exactly like it would if you were exposed to the disease. After getting vaccinated, you develop immunity to that disease without having to get the disease first. This is what makes vaccines such powerful medicines. So unlike most medicines which treat or cure diseases, vaccines actually prevent them. So whether you are newly diagnosed with rheumatoid arthritis or another inflammatory arthritis, or have been living with it for many years, you need to know why it's important to get vaccinated against infectious diseases. Simply having RA or some form of an autoimmune disease with a weakened immune system or decreases your body's natural immune defenses and therefore increases your risk of serious infection by 2 or 3 times. Add to that, most people who have these conditions, they're taking medications, or at least they may be taking medications in the future that will decrease the body's immune response as well. So you have an inherent autoimmune condition that will lower your immune defenses, and then you may be taking some medications that also could lower your immune defenses. And so kind of this double whammy may leave you vulnerable to other infections. And so because living with these conditions increases your risk of infection, it's even more important to get vaccinated against these infectious diseases so that they will have less of a response or you won't get a response at all. So the question that I hear often is, so which vaccines do I need, or which vaccines should I get? And here are the vaccines that you need to have. So this chart is very busy on the front end. And this is the CDC's 2018 recommended immunizations for adults, and that's the Center for Disease having me Ben, Center for Disease Control and Prevention. There we go, Center. And so just to orient you to the chart, and I'll show you a shortened version in a second, is you'll have columns that are going from left to right. In the first top left-hand column will be conditions, and then going across from left to right will be different vaccines to get. So I've highlighted the specific vaccines for the category, which is weakened immune system. And so green is broadly the vaccines that are recommended for you. And so it says this vaccine is recommended for you unless your healthcare professional tells you that you do not need it or you should not get it. And so that would be the flu vaccine, and of course the tetanus and pneumococcal and HPV and Hep B, or the Haemophilus influenza type B. You should get those for sure. And then there are other vaccines that are recommended, so in blue, and it may be depending on the certain risk factors that you either may be encountered or that may encounter you or you may be around. And so those have a bit more specific recommendations. And then the other, I suppose, lavender color, that kind of looks lavender. I think that one, those are the ones that you should not get. And typically those are the live vaccines. And as I mentioned earlier, those are going to be much more of a potent type of a vaccine initially, and so those are not recommended for those living with weakened immune system. So which vaccines do you need? And as I said, non-live vaccines, that's kind of something that a take-home point is you should not receive live vaccines. So there are certain vaccines that are recommended, and of course, with having a weakened immune system, these are on the basis of increased risk of disease, and that is if the vaccine is withheld. So these vaccines are definitely recommended. So all of the inactivated vaccines, and that was the second type of vaccine that I had showed you, those can all be administered safely. And once again, staying away from the live vaccine. So the 5 that I'm going to highlight today are, and these are recommended for adult patients with rheumatoid arthritis, but also other autoimmune conditions and inflammatory arthritis conditions. And the ACR stands for the American College of Rheumatology. So it's kind of per their guidelines that they're recommending these specific vaccines for these specific conditions. So influenza, pneumococcal, herpes zoster, hepatitis B virus, and human papillomavirus, or HPV. So to kick off, it's the seasonal influenza vaccine, and as we are in the middle of flu vaccine, it's ever appropriate. So it's very important to get the flu shot each year, and this is because the flu virus also known as the influenza virus, it's constantly changing and the vaccine is updated yearly. So ACIP, which is the Advisory Committee on Immunization Practices, they recommend that pretty much everybody should receive the flu vaccine this season. And they are a branch, or they are from the CDC. So they recommend that pretty much everybody needs to get the flu vaccine. Things that they don't recommend are the live attenuated version or the nasal spray, and that should not be used. And if I remember correctly, I don't think it's being recommended for many, if any, people because it's not really working too well. But for our group here, definitely it's a live virus, so we want to stay away from that one. So immune responses to vaccines might be blunted in those immunocompromised persons. And another thing to consider is you definitely get it each year, but also the timing of vaccination might be a consideration. So for instance, if you're taking certain medications that you may want to speak with either your pharmacist or rheumatologist about when to take it in relation to biologic medication, or maybe a DMARD, a disease-modifying anti-rheumatic drug. There are some considerations to take with the flu vaccine, and then how the timing of that should be. Maybe waiting for a few weeks, or skipping a dose or two based on the timing of it. That would be an important consideration. So in addition to the flu vaccine, there's the pneumococcal vaccines. So these are two vaccines that are recommended. So respiratory infections, they're among the most common infections in inflammatory arthritis conditions, especially in RA, and the complications of these infections could be very severe. So pneumonia, which is caused by a little bacteria called pneumococcus, it's one of the most severe complications of respiratory infections, and it is one of the leading causes of death from infection in RA. There are two types of pneumonia vaccines that are used in combination, and it's Prevnar and Pneumovax. If you want to get very technical, PCV13 and PPSV23, but you can call them by their regular names, Prevnar, Pneumovax, and pharmacists, rheumatologists, general practitioners, they will know exactly what you're talking about. And so these are conjugate vaccines, as I mentioned earlier. This is the third type that I showed you. They generally stimulate a more potent immune response than do some other types of vaccines. But in general, your age, whether or not you have had a vaccine for pneumonia, and the timing of this vaccination will determine your next steps. And so on this next slide, what I'm going to show you is, it looks like a busy schedule, but it's really just to illustrate the fact that there are certain time periods to take these vaccines. And in general, if you don't remember or you don't know, it's probably likely that you're due for one. And it's a good point of conversation starter with your rheumatologist or your pharmacist or your general practitioner. So for those who are immunocompromised, autoimmune conditions and inflammatory arthritis, this is the kind of base schedule. And really it's get introduced to the Prevnar, and then you wait some time, and then you're going to have a dose of the Pneumovax, and then you're going to wait some time, and then you're going to get introduced to a second dose of Pneumovax, and then you're going to wait some time, and then you're going to have the Pneumovax for a final time after the age of 65. However, there are many different iterations of this depending on where you are, different conditions, and of course, what age you are. But as I said, if you don't remember, then it's likely that you're due for one, and to definitely contact the healthcare provider that you normally go to determine your history with that. And below are the recommendations from the American College of Rheumatology, and these are going to be in relation to those who are also taking some sort of biologic or disease-modifying anti-rheumatic drug therapy. So pneumococcal vaccines, they are recommended to do it before you initiate those therapies and while already taking them. So using appropriately the indicated, so the kill vaccines, the inactivated ones, and those are the pneumococcal vaccines, PCV13 and PPSV23, doing this earlier rather than later, so in early or established conditions who are currently receiving biologics. So it's strongly recommended that if you haven't gotten it, to definitely get that one. The next one is herpes zoster. This is there are two herpes zoster vaccines that are available right now. And historically, the first one is a live vaccine, and it is Zostavax. I lost the name. But what Zostavax and then the newer updated version, Shingrix, what they do is they protect against the virus that causes shingles. And that virus is called herpes zoster. And it is a nasty infection. It causes painful skin rash and often blisters. So rheumatoid arthritis and inflammatory arthritis and autoimmune conditions, they are also at increased risk of getting this. So shingles, it is caused by the varicella zoster virus. And that's the same one that causes chickenpox. So it's very likely that many, if not all of us, have been exposed to chickenpox. I want to say most people born in the 30s, 40s, 50s, and beyond have been exposed naturally to chickenpox. So it's kind of lying dormant in our body. So after we've had chickenpox as we were all young, some of us, the virus stays in your body and it can cause shingles later in life. And so that's another reason that it's there, and it can cause flares. So getting vaccinated against it can definitely help. And most recently, in 2017, there was a recombinant shingles vaccine that was approved. As I mentioned, it was Shingrix. And it is as is the Zostavax, for the prevention of shingles. And so when they did the clinical trials and the tests on it, it showed that it was very effective in preventing shingles. And as opposed to a one-shot dose like the Zostavax, the Shingrix comes in a 2-dose piece. But there are some exceptions, unfortunately, and then we will talk about that very soon. So getting to recommendations from different bodies. So what I have here is on the left-hand side, on the far left-hand side will be a recommendation from a body, so the FDA, the Food and Drug Association. And then going from left to right, you'll see in the first column, or the second column, will be a Zostavax, that's the live vaccine, the historic vaccine, and then the newer non-live vaccine, which is Shingrix. And so across the board, it's indicated for the prevention of herpes zoster in individuals who are over 50 years of age. And from the Advisory Committee on Immunization Practices, and this is from the CDC, so now still talking very broadly, very general, not autoimmune specific. We're talking that the ACIP says that over 60 years old should receive 1 dose of the herpes zoster, so Zostavax, regardless of whether they've had a prior episode, and of course with chronic conditions. But it's contraindicated, so that means that it's not recommended for people in pregnancy and people with severe immunodeficiency on high-dose steroids, high-dose methotrexate, and other medications. So as we said before, since it's a live vaccine, it's not recommended. And it's kind of mirrored. So, and then Shingrix on the other side, it's recommended for healthy adults over 50, so a 10-year age difference. And then for adults who have previously received Zostavax to prevent shingles and related complications. And in a nutshell, or in a vacuum, Shingrix is preferred over Zostavax for the prevention of herpes zoster and related complications. Unfortunately, this is for healthy individuals or individuals who do not live with altered or weakened immune systems. And as you can see from a more specific body, more relevant to autoimmune conditions such as rheumatoid arthritis and whatnot, the American College of Rheumatology has recommendations as well. It has it for Zostavax, which is in RA patients over 50, and it's recommended to be given before a patient starts a biologic medication or tofacitinib. And if they're currently receiving biologics, then of course the live attenuated vaccine, such as Zostavax, should not be given. So a little bit different recommendation there. But after giving the Zostavax, there should be a 2-week waiting period before starting biologics. And so this would be under the guise of a rheumatologist or someone. Currently, there are no addressed guidelines for Shingrix. It is a bit more of a hot topic at this moment. However, there are new guidelines that are being written as we speak. They should be available in 2019, 2020, maybe 2021, depending on how the data is being collected and then just kind of parsed through. But currently there aren't very specific, there are more vague guidelines or guidance rather for, if there is a patient, let's say, who has rheumatoid arthritis and is taking a biologic and they want to get Shingrix, what should they do? And so the communications and the talk behind that has been a bit more vague, but the short answer is we're waiting for more data to kind of come so that that can be appropriately addressed, so that people can know, or so that people can know what they're doing, before just kind of recommending it in general. But in a nutshell, for the Zostavax, it's best to get this vaccination before starting a biologic or a small molecule or something for the condition that you're taking, because it's not it's not indicated for certain individuals taking certain medications. So when in doubt, initiate that conversation with your rheumatologist or your pharmacist to get specifics. On this next page is just kind of the contraindications or the non-recommendations for each vaccine. So the live vaccine is contraindicated in the immunosuppressed or the immunodeficient, including those on immunosuppressive therapy, so current therapy. And of course, there's deferred vaccination, so that really what it's saying is there needs to be a washout period before or after getting the vaccine and taking the medication. And as you can see on the right-hand side for Shingrix, the safety and efficacy are currently unknown in specific conditions, and so we're waiting on that data and those numbers, if you will, to kind of be collected, and so that we can make a more informed decision. But the big difference between the two, besides live and non-live, is that the Zostavax is a 1-dose shot, and the Shingrix is a 2-dose shot, and the 2 doses will be separated by about 2 to 6 months when it is given. Moving along to the next one is the hepatitis B vaccine, and this is indicated for pretty much from the FDA, prevention of infection caused by all known subtypes, and for individuals of all ages. From the ACIP, it's infants at birth, unvaccinated children and adolescents over 19, and unvaccinated adults at risk for infection and for environments that are around these types of risk factors. And of course, the ACR strongly recommends for unvaccinated adults with RA and also other inflammatory arthritis conditions, that if the hepatitis B risk factors are present, then prior to taking therapy, so with DMARD or biologic therapy, to get vaccinated against hepatitis B. And this one is a 3-dose schedule, and it's an inactivated vaccine. And the last one that is recommended, or one of the 5 that I'm highlighting here, is the human papillomavirus, so that's the HPV vaccine. And kind of across all 3, it is definitely recommended. And typically, we'll see this being given in younger males and females. And but to highlight what the ACR is saying, it's unvaccinated patients with RA or other inflammatory arthritis conditions who are at risk or age appropriate. So, and that's prior to taking medications or while already taking medications, these DMARDs and biologic therapies. And so it is important to get this medication as well. And this is a 3-dose series, and it is also an inactivated vaccine. So as I showed before, the live, the inactivated, and of course the conjugate. So just to kind of summarize what we've talked about so far and leave more time for questions at the end, vaccines work by mimicking disease agents, and they stimulate the immune system to build up defenses against them. They're important for you because they prevent infectious diseases and they lower your risk of infection. So for adults living with RA or other inflammatory arthritis or autoimmune conditions, be sure that you are up to date with the following vaccines. So yearly influenza, pneumococcal, if you can't remember or if you don't know, it's likely that you're due for a next one. So you might as well start that process. The herpes zoster vaccine, the hepatitis B vaccine, and the HPV vaccine. And with that, I will open it up for questions and comments and discussion.
Thanks, Justin. Yeah, so there's a lot of questions coming in about this topic, and so I guess some of this may just ask you to reiterate some of what you talked about a little bit. But I'll start by saying, if you wouldn't mind talking a little bit about the research interest group that you are leading within the Autoimmune and Systemic Inflammatory Syndromes Collaborative Research Group at PCORNet, on vaccination concerns. And the reason I bring it up is because some of our partner patient-powered research networks in this collaborative research group, of course, are pediatric patient populations. So Vincent Delgaizo, who I know through this work, submitted a comment, and I think just this sort of reinforces the importance of this area for research. He's a co-PI of the Partners Patient-Powered Research Network, which is pediatric arthritis, pediatric rheumatology, and he's also a parent of a child with juvenile idiopathic arthritis. So one of the struggles, I think, for them is that it sounds like the current recommendations are to vaccinate with MMR and V if a patient is in unmedicated remission. But pediatric groups are interested in the topic because parents often have trouble deciding what to do, parents and pediatricians, because for the most part, it sounds like disease flares can occur after infection, but you activate the immune system that goes haywire. So they're being asked to knowingly infect the children, which might cause a flare. So they're trying to kind of weigh the options. Is the risk of getting measles higher than the risk of having a flare from the vaccine? So there's just a feeling like a lot more data needs to be collected and shared. So I wondered if you had any comment about that, or about the research interest group in general, or even just the idea that I think when people talk about vaccinations, it sounds like I think people still perceive it as you're infecting someone with the virus or with that. But I think maybe if you could just reiterate how you explain how a vaccination is different than actually getting the infection.
Absolutely. And so, yeah, I think all of that's important, and there's a lot of research that can definitely be done and needs to be done in all of these areas, especially in the pediatric section. There's a lot of unknowns, and of course, there's a lot of just what do you do, and the things that you're weighing. How are you making your decision, and how are you navigating this? And it seems to be there's a lot of things to consider when doing it. And of course, so I definitely agree, and am a proponent of having more type of research and or just data or knowledge so that we can make a better decision about what is better for quality of life, or getting vaccinated and getting covered moving forward. As far as the research interest group, we would hope to tackle some questions like that, and more broadly, kind of where we are at the moment is trying to understand what types of hesitancies and barriers there are with getting vaccinated. And so for the pediatric section, that would be a really interesting discussion to have, just kind of brainstorming, because the hesitancy to get vaccinated it doesn't seem to be hinged on a fear of should I get it or not. It's, well, I know I should get it, but if I do get it, then something else that we know could happen, versus if I don't get it, then something worse may happen. And so which one is it? Versus, I don't know if I want to get vaccinated because I don't think that they really work, or I'm getting a full-blown infection or something. So I feel like they may be coming from two different points, and that would be really interesting to kind of see how we could, or what we could do to address that. And then kind of coming back to both adults and to children, really perhaps identifying and understanding like what are the perceived barriers to getting vaccinated or not vaccinated. So if that's from one section with the pediatric population in that specific population, or if it's just kind of across the board. And seemingly, despite me living in a bubble and studying this stuff all the time, I want to be sensitive and aware of how others perceive the information that is sent to them or given to them or available to them to look up or to find their own way of researching these matters. And so somehow generating content to give people better access to better education, if you will, about maybe some misconceptions on our end, perhaps, that may be misconstrued with the way that information is conveyed, or the speed at which information can be portrayed these days, and finding a way to best educate and inform and work together to figure out, all right, how are we going to best demonstrate that these levels or these types of vaccines are doing what they're doing, as you had mentioned. So what they're doing in the body and how they're helping or what they're doing for the body to kind of help allow it to remember when they get encountered again, that it's going to increase those defense mechanisms.
Thanks. So again, this is maybe a little bit just kind of circling back and clarifying some of what you discussed earlier in the presentation, but Michael and Brenda have asked some questions about the live vaccine versus the non-live vaccine. And so a couple kind of series of questions around this. Why does your doctor say if you have RA or some autoimmune condition to get the non-live vaccine? What's the fear, what's the worry, that they suggest that? And is it ever okay to get a live vaccine? And do you have to take a medication holiday to get one if you have an autoimmune condition? And I realize, all of this, of course, is within the context of people. This is just information for people. So people, of course, should go to their doctor and discuss any of those kinds of treatment decisions with their own physician. But I wondered if you could just comment a little bit more on the difference between the live vaccine versus the non-live and why there's some caveats around getting a live vaccine.
Yeah, so I think kind of historically and a bit theoretically, the worry is that with the live vaccine, to what extent is it ramping up or maybe even distracting the immune system? And so when you're introducing a live vaccine in and it's kind of stimulating or allowing the immune system to know that an imposter is there, and then it's doing its cascade, and I'll kind of scroll over to kind of illustrate this a little bit better. It's initiating its cascade so that it can better learn what's going on. And so as you see on the screen here, a live vaccine is introduced, and it's a bit more aggressive, if you will, across when you're comparing it to a non-live vaccine. And it is trying to invoke this cascade of eventually becoming to a memory cell that will remember that certain type of vaccine antigen, or the antigen that's closely related, if not the same thing as the infection, and allow it to remember that. So I think that the fear is that while the defenses are being distracted by a live vaccine, or perhaps there are differing levels of people's immune systems within weakened immune system individuals. So if we're just talking blanket autoimmune conditions, so everybody is operating with less defenses in general. And it's not that everybody's at, let's say, 50%, but some people could be at a range of 0 to 50%. And it seems that with a live vaccine, it's going to invoke a more aggressive primary response. And the idea is that maybe the primary response is too aggressive, or it's distracting too much, that another infection or another something could slip in and wreak havoc, while the initial or the only defenses that are available are there kind of dealing with the initial live vaccine. So I think that it's more of a caution and a worry. And of course, there's also some data to back up the potency of the live vaccines. And so there are some labs that can be drawn that can tell you the levels of defense cells that are kind of being initiated. And so I'm thinking that it probably foremost is a cautionary thing to recommend an activated version of a vaccine versus a live vaccine.
Okay, so it's for healthy individuals, there's a very small risk of that live vaccine could actually harm you, but in someone with an immunocompromised system, they might be at higher risk of the live vaccine actually causing some problems that would distract from or affect their health in other ways.
Exactly. And with healthy individuals, the live vaccines will be recommended, because what you typically see is the live vaccines are normally one-stop shots. And with the less live, the inactivated or the weakened, you may need a booster every 5-10 years, and that's because it's just not as strong of a response that it initiated on the front end. So, but with healthy individuals, there's not, unless your doctor specifically, or if you have a condition. So I can back up and say some other non-autoimmune conditions, such as having diabetes mellitus, so type 2 and type 1 for sure, but and some other chronic conditions do fall under the weakened immune system umbrella, very, very lightly and broadly. And I think the important piece is to, with your primary care physician and pharmacist or rheumatologist or whomever, them having a more intimate knowledge of your medical history, medications that you're currently taking, and what you have, can make a more informed decision than having a blanket, yes, everybody who is healthy have a live vaccine and everybody who's not don't. So I think that's why these recommendations are a little bit more broad and vague and proceeded with caution, because as we have more information available, we can make a better informed decision.
Okay, great. So just to call out too, while Justin was presenting, I posted a few things in the chat window. So links to the other webinars, links to an article, like related to what you talked about, that there's sort of a double whammy, that the autoimmune condition itself causes an increased risk of infection, as well as being on an immunosuppressive medication can also cause an increased risk of infection. So that's why it's so important for people with an autoimmune condition to be tuned into vaccines and making sure their vaccinations are up to date. So a question is related to, I'm going to kind of go through some of the vaccines that you addressed, of the 5 that you called out here, the flu vaccine, pneumonia, and so on. So some questions about the flu vaccine. So I know, just anecdotally, personally, I used to be a little nervous to go get my flu vaccine personally, because they give you the material after, and they say, oh, you may feel a bit lightheaded or tired or whatever after, for the next 24 hours or whatever the period is after you get your flu vaccine. And so it makes it sound, it makes it sound like, oh wow, they're giving me the flu. But I think what I've since understood, and I think you can correct this, is that it's really, I feel sometimes I just need to go lie down or kind of rest for that next 12 or 24 hour period after getting a flu vaccine, because it's stimulating my immune system to sort of get the defenses up and going. So it's not actually causing the infection, but because our immune response feels like, that's what it feels like when we get a cold, it's our immune system kind of ramping up. So can you talk a little bit about that? Because there's some questions about, let's see, for example, someone said, can the flu vaccine make other medical conditions worse? I have chronic migraine, and I feel like the flu shot has made my head worse in the past, but maybe that's just a coincidence. What are your thoughts? And I think that's and then I'll get to the pneumonia vaccines. And the other question about flu was, recently I've read that the flu vaccines are just hype from the pharmaceutical companies and are actually more harmful for people with compromised immune systems. So can you comment on that?
Sure. So to kind of address them as I heard them, so I think initially the flu vaccine it does ramp up or engage your immune system. And so as you mentioned, Ben, when you get a cold, you kind of feel a little crummy and you feel a little tired and you feel a little just kind of out of it. And that's likely, or it seems like that is your kind of a cycle of your immune system, that it's ramping up and then it's attacking the invaders, and perhaps it's getting you to be still for a bit and allow it to pass. And that's just anecdotally, but in my experience and from others that I've known who've gotten the flu vaccine and who get it, there's definitely for a lot of them, the main thing is fatigue and just kind of feeling a little off or weird or something. And I think that it's because your immune system is being ramped up a bit to kind of learn what it is and how it can approach it. But for the flu vaccine making other medical conditions worse, not that I've heard of, and it could be something that you could definitely or should definitely monitor. So are there other things, maybe when you're sick, separated from getting the flu vaccine, that could also be happening in accord with the migraines getting worse? There are a lot of things that, there's a lot of kind of pomp and circumstance around the flu vaccine in general. And so there is this kind of maybe inbred anxiety getting a flu shot because of what you may think might happen, or maybe it does happen. And of course, to different individuals, it's going to be on a different scale of the minor symptoms that it's going to give. And it's not to say that it doesn't make the migraines worse or your conditions worse, but it is to say that it is ramping up the immune system a bit, and it can also be likely that it could be happening in accord with making you feel crummy, and then perhaps also that could be a trigger for a migraine. So maybe I'm wondering if when you get a seasonal cold or something, if that while you have a cold also has an effect on the migraines or other conditions. But to my knowledge, I haven't come across that specifically, but that's an interesting perspective.
Okay, but the key point is a vaccine like the flu vaccine, any vaccine, it's really meant to train your immune system to quickly and more robustly respond when it's actually encountering a real threat from that particular virus. But the vaccine itself, there's just not enough of, it's not enough. It's sort of wearing a mask or whatever to help the body get ready to recognize it in the future. But to practice, so it's just tiring.
So you may actually get not get the flu, but you may encounter the flu after you get a flu shot. But your flu that you've encountered, since your immune system has kind of been primed for that or ready for that, your flu will be less or not as bad as if you had it without the flu shot. And so you may say, "Oh, I got the flu anyway." Well, that is true. However, it's not going to be as bad. So it's still kind of a defense against a full-blown flu versus not getting the flu. So as you said, it kind of just ups the defenses for it, and it can tamper it a bit.
So a few questions about the pneumonia vaccine. And this is more, let's see. There was a question, I don't know if you know the answer to this, but there's a question about the prevalence or incidence of pneumonia in patients with RA or other autoimmune conditions compared to the general public. If it's more common to get pneumonia for people who have rheumatoid arthritis or another autoimmune condition. Do you know anything about that sort of heightened risk?
So specifically, I'm not familiar with it specifically. However, for those not taking medications who would also be decreasing. So let's say level 1 just have the autoimmune condition, and then the immune system is lower, and there is an increased risk or incidence rather of pneumonia in people, let's say with rheumatoid arthritis, and versus the general population. Now, for those taking medications as well, I think that there are numbers on that as well. But I could get back to whoever had asked that question to find specific numbers or studies for that. But there are studies that indicate higher risk of infection.
And then how effective are the pneumonia vaccines for someone who's taking, someone asked specifically if they're taking methotrexate and low dose steroids? Are you able to comment on what taking a DMARD like methotrexate or a glucocorticoid like prednisone or low dose steroid does to the impact of the vaccine or the effectiveness of the vaccine, like a pneumonia vaccine?
Sure. So there are numerous studies out that kind of give the basics on, if taking this medication at this dose or steroids at a cutoff point, high dose or low dose, that it may or may not affect certain vaccines. So for pneumonia, and I will need to double check, but if I remember correctly, there are certain vaccinations that when someone is taking either DMARDs or biologics, that it would have an effect on that vaccine. And with the flu vaccine in particular, there was something that recently came out that with people who are getting the flu vaccine and who are also on methotrexate, that the paper was in a group of patients with rheumatoid arthritis that delaying the next 2 doses of methotrexate, so having about a 2-week window of skipping the methotrexate after taking the flu vaccine, actually was a bit better on the front end, or on the back end rather, for outcomes versus taking them at the same time. So taking methotrexate at the same time as getting the flu shot was for the group that did that versus the group who kind of held it for 2 weeks. The group who held it for 2 weeks actually fared just a little bit better. So the methotrexate didn't decrease the effectiveness of the flu vaccine as much as it would if they were taking it together. So there are some medications that can have that effect on pneumonia vaccine or the influenza vaccine or other vaccines. And it really depends on which medication you're on and which ones can have an effect on which vaccine.
So again, yeah, it's very complicated. I mean, I think one thing I'm taking away from this presentation is vaccines. The idea behind them is quite simple. That it's introducing a copy of something into your system so that your immune system is trained to respond quickly and robustly in the future. But I think the sort of recommendations around different vaccines and for different people, it's quite a bit more complicated, as your slides demonstrated. So I think this is a reminder that people work with their doctor to make these decisions. Do you have one question that comes up sometimes, because people often have more than one doctor. They'll have a family practitioner, family doctor, or primary care physician. But then they also have a specialist, like a rheumatologist or a dermatologist if they have psoriasis, or a gastroenterologist, with a IBD or Crohn's. What do patients like that do? Who do you recommend working with for to make decisions about vaccinations? Should you work with your rheumatologist? Should you work with your primary care physician? Should you try to work with both simultaneously? How do you handle that?
I think that's a great question, and that's actually one I've been trying to tackle through the literature now, and also anecdotally through many of my friends who I went to pharmacy school with are pharmacists, and so I see how they respond to somebody who has a specialist and they come to them with vaccination-related questions, whether they're in a retail setting or in a hospital setting, and of course other doctors, general practitioners, and then of course rheumatologists, like who's fielding those questions. And so my perspective, or what I would say, is to initiate the conversation with, if not everybody, the one that you feel most comfortable, or the one that is taking the most care of you, I suppose. So if the rheumatologist is the one who is having a good dialogue and a communication with you, and of course they're going to be the expert with the specific medications that you're on, that would be the person to initiate the conversation about vaccination. However, if it's more of a hands-off, and then the GP is the general practitioner, is the person that's doing it, then initiating that conversation there with the general practitioner. But I think that in an ideal world, this would all be in a record somewhere, or it would be accessible perhaps through a feature on a special iPhone app like Authorized Power, where it's on a medication list, and you can know and see what you have and what you've taken and what you're on, and then you can show that information to whomever it is, whether it's the pharmacist or the rheumatologist or the specialist or the general practitioner, to kind of just ask about the concerns of, I'm taking these medications I'm feeling, or I know that I need to get, or I'd like to get vaccinated against some of these infectious diseases, and doing that. However, I realize, or I understand that it can be hard to initiate those conversations when time is limited and there are other things to talk about. However, I would encourage you to start the conversation with whomever you felt most comfortable with, having that discussion with, and then, or if needed, to print something off and to initiate the conversation. So I think initiating the conversation is the start, and just going from there.
That's great. And I think we're going to end up with more questions than we have time to answer. So I'll just propose we respond to one or two more questions here. One question came through. It says, what precautions need to be taken when another member of the family, a member of the household, receives a live vaccine? So I guess for me, I hear that. I feel like that's a misunderstanding of the way vaccines work, even a live vaccine, because it's not communicable in the way that an infectious agent might be. But maybe I'm wrong about that. Are there precautions that people need to take if someone close to them is getting a live vaccine? Does that have any impact on other people in the household?
I would have to get back and check. I've always thought of it the other way around. Of if someone is in a weakened immune state, and if they haven't been vaccinated against X, Y, or Z, then they should limit contact, or they should not limit exposure. But on the other hand, I'm with you, and that doesn't sound like, that's not how they work. But before I do a blanket recommendation or a statement, I'll reply back, and I can respond to the list of questions as I see that they're pouring in, and I can also respond to that one just to make sure. But I'm fairly certain that that's not a concern, but I'll get back.
Okay. And one other question too, if someone has their immune system is suppressed because of a medication they're taking, or that their immune system is a bit challenged because of an autoimmune condition, is there any logic to getting a higher dose? I don't know if that's possible, like a stronger dose, a high-dose flu vaccine, because that will be more effective for that person? Is there stuff that you've come across about the sort of strength or dose of a vaccine based on someone's the immunosuppressive medication someone might be on?
Well, there was something that recently came out that was recommending that, and as these papers do come out, and sometimes with headlines and highlights, that the headline and the highlight can rule the knowledge. But for this paper in particular that I think you're referring to, or maybe the question's coming from, it was patients who had seropositive rheumatoid arthritis, that they fared a bit better when they took the high-dose flu vaccine versus the standard vaccine. So not necessarily based on the medications that you're taking, but the condition that you have. So, but that could probably be extrapolated to rheumatoid arthritis kind of in general. But there are some studies that are showing that the high-dose flu vaccine is a bit more effective than the regular flu vaccine.
Okay, great. Well, thank you very much, Justin, for your time with us today. This is clearly a really important topic, one with a lot of interest, still a lot of questions that people have. So we look forward to hopefully addressing this in a future webinar, perhaps. But in the near term, we'll upload the recording of this webinar, and with a summary page of what we learned from this, and try to get some follow-up questions to you so we can get those responses posted as well. So thank you very much for your time, and thank you everyone for attending. And we look forward to letting you know about our next webinar in the next few weeks for December. So stay tuned for that. But the next topic is going to be in the world of inflammatory bowel disease. So thanks again, Dr. Owensby, and thanks everyone. Have a great evening.
Thank you so much. Thanks everyone.